Good afternoon, everyone, and welcome to the meeting.
Thank you.
As your notice on your screen will tell you, we're recording this afternoon's meeting, and that's the purpose of governors who can't join us today, but also for any members of the public who aren't free or available to dial into the meeting and observe it in real time, but would like the opportunity to catch up with it later. So just to note that, please. I'm going to go to Nicola, if I may, to give us apologies for the meeting.
I've got apologies from Anne Margette, Claire Whitbread, Glenys Bartle, Judith Rees, Martin Rose, Michelle Brown, Steve Collis, Mick Portman, and Berenice Groves.
Many thanks, Nicola. Which brings us on to declarations of interest. Does anybody need to notify us of a change to the register of interest or any particular declaration in respect of today's agenda? No, I'll take that. Oh, Jane.
Thank you, Helen. I've just notified John of a small amendment, which is a change of name to the Carers Trust listing on my declaration. The name change has gone from Carers Trust to Vidas, but that's purely a name change, nothing else.
We'll update the register accordingly, Jane. Thank you for informing us. And there's an opportunity normally, if when we're meeting for real, in person, I should say, for questions from members of the public. I don't know, Gillian, if we have any members of the public dialed into the call yet. Are you there, Gillian? Well, Gillian normally gives me an update. Oh, none at the moment. Thanks, Gillian. I can see that by text. So there's none at the moment, but as ever, we're going to provide another opportunity at the end of the meeting, should anybody join us and should there be questions they want to raise, because obviously it's important to extend that opportunity on the back of people having had the opportunity to hear the discussion, should they wish to do so. So that concludes the preliminaries, if we can call it that, and takes us on to the next section of the agenda about well-led services. And we're going to go in the first instance to hear Angie's Chief Exec update. Angie, all yours.
Thanks, Helen. And a verbal one from me today, continuing the theme as we've had at recent meetings, given the ever-changing position inevitably dominated by COVID at the moment. So in terms of our operational position, extremely challenging and has been over the last couple of weeks. We reached, I hope, what was our peak of COVID patients in our beds.
Playgrounds. No, four playgrounds. 3 or 4 community centres.
Thank you.
Whoever's telling us about playgrounds, if you'd be kind enough to go on mute, please. Many thanks.
Thanks, Helen. So in terms of our position today, we have 180 COVID positive patients in our beds. That 193 was, I hope, our peak weekend before last. We're not seeing a sustainable drop or as quick a drop as we did from our peaks in wave 1 and wave 2. And you'll recall that our peak in wave 1 was high 70s, so almost 3 times the number of patients that we had in wave 1 peak of COVID positive patients, which clearly presents us day to day with operational challenges when we've also got 300 non-COVID patients in our beds. So our attendances through our emergency department and those patients who we continue to operate on for cancer and urgent surgery are all being looked after as best we can at the moment. Our critical care capacity is full, and we continue to work with our network to transfer patients to decompress the unit where we can, and we still work as a national critical care system as we are at the moment, where occasionally we will accept patients from elsewhere if we have capacity. I thought it worth noting in all of that challenging picture the good progress that we've made on vaccinations. So thank you to our RPC colleagues who continue to work in the PCNs as part of the community vaccination programme, which is where the large part of the activity is currently taking place. And you'll potentially have seen that there's a pharmacy site, couple in the system, but one in Chesterfield coming online this week. So we continue to roll out in different settings for vaccination. Our hospital hub is paused at the moment so that we could support community work and our hospital patients, and we'll restart the hospital hub for the second doses, which is the 1st of March. In terms of just a couple of areas to note from me, we continue to do what we can to restore and recover our services. Clearly extremely challenging at the moment given that operational pressure and our staffing position, which we're still hovering around the 10% of sickness absence amongst our staff, half of which is COVID. But where we can, we're continuing to deliver our diagnostic services, for example, which the teams are doing really well at continuing to support. Health and well-being for all of us is fundamental, and lots of support for all our staff, both currently and we know over the coming months is going to continue to be needed. So lots of work in that area, and I'm sure if there's questions then others, including Zoe, will contribute to that. And the last introductory comment from me, just to say thank you again to everyone for contributions on our 5-year strategy, which is starting to come together and will come as a final draft version in the next weeks for getting that completed for the end of March. So I'll pause there, Helen, and myself and exec colleagues are happy to take any specific questions.
Thanks, Angie. Now, I'm going to do some of the items that arose at the Governor pre-meeting, which is agenda item 7, Angie, now. In fact, I'm going to take all of them now. Insofar as any of the items that were raised need to be shared with exec colleagues because they play in well to your report. So we'll do those now, and then the others we needn't go through now because they've either been answered in the meeting or there's something that we're going to take away, and then John can feed back in the normal way with that addition to the note of the meeting. But some are really germane. So I'm going to start with one that Norman raised and you've alluded to, Angie, which is about could you give us a real flavour of the grip we have on doing other work, non-COVID work? So, you know, everyone sees the daily sheet that tells us how many procedures have had to be stood down and why. But I suppose it's just take one step back from that. And, you know, we're aware about the amount of work and planning that's going into recovery. But what's the sort of likely scale of the backlog and how fine are the judgments? And, you know, what difficult decisions are we needing to make about what work has to be postponed and what's the scale of that?
Okay, and Helen and Krishna may want to come in, but if I kick off, if I say that our unplanned care activity through ED continues to be almost as busy as it was last year as this time, hopefully that gives colleagues a flavour for that activity. We had 107 ambulances arrive day before yesterday, which is really high for us. So we continue to provide that urgent care, and we're working jointly with our partners in the community to work on the urgent care offer that we have, so that wherever possible and where appropriate, patients who need urgent care but not necessarily A&E are given that advice and that treatment, so we can support our A&E staff to concentrate on those critically ill patients. Clearly some of those patients coming through ED will need emergency surgery, so we continue to run emergency surgery and trauma surgery every day for those patients that need it. Our children continue to be seen, our maternity services continue to run as normal. In terms of the planned care and diagnostic services that we provide, we monitor weekly, and I actually chair the planned care board for Derbyshire, so I can see across the whole of Derbyshire and the Midlands where we're at. and to give council some assurance, our diagnostic performance remains really strong. So despite everything and our staffing challenges, our numbers of CT scans, our MRI scans are at a similar rate to, again, where they were pre-COVID, which is really good news. We have some challenges in some diagnostic areas, and endoscopy is a particular challenge for us, but we've just done some work to get some extra support in there so that we can get back to the position, again, that we were at the start of the pandemic. Our cancer overall, it was the 2-week wait, it's now the 28-day diagnosis. Performance remains really strong in Chesterfield. A few more challenges across the Derbyshire system, but we continue to get those patients seen at the early part of their pathway, and clinicians will prioritise those patients who need cancer surgery, working with the network. The particular challenge around ITU capacity is the one that every day now we have clinician discussions about how we manage cancer patients that need critical care. Bless you, Helen. And that work continues. And then in terms of our planned care, so the patients that we refer to as being on routine elective waiting list, which feels far from routine for a lot of our patients who are waiting a long time for those procedures. All of those patients are reviewed by the clinical teams, so that we keep that overview, that should they condition deteriorate, or the clinicians in consultation with GP and patient want to bring patients in sooner, then we do. But pre-COVID, we had no patients on that waiting list over 52 weeks. We've now got around 1,000 patients in Chesterfield. It's closer to 3,000 in Derby, waiting over 52 weeks. So inevitably that delay in those routine referred to patients is having an impact, and that's the work that we review every week to do what we can, whether that's working with the independent sector, so Barbara in particular for us and Thornbury, to get some of those procedures done, and working with GPs. We've done some really good work that Hal may want to come in on, working with consultants and GPs to try and make sure that only patients that really need a hospital referral do get that. And our dermatology service is one of our real shining examples at the moment of how they've used technology to avoid patients necessarily coming into hospital and getting advice for GPs to see those patients in primary care. I said I was going to do the introduction, but Hal will tell me now I've left nothing for him to add, but I'm sure there is.
Well, I'm just about to say, Angie, that not only is that magnificent in terms of us having an understanding of the grip that the chief executive has on the business of the hospital, but it bears enormous testament to every person in the hospital's focus on looking after our community, COVID or non-COVID. And as we've always said, the test of our response during this period will be around total mortality. And that assurance you've just given us around the extent to which we're just getting across that in the way we are is nothing short of magnificent. So thank you very much. I'm not going to invite further comments. I think you've really done that great justice, Angie. Now, with apologies for jumping around the agenda a little bit, and I'm going to come back to you with some more questions from the Governor's pre-meeting, Angie, before, and then we'll open it up to further questions, because of course at this fast-moving time it's important that we've got the opportunity to do that. But we were very keen that there was an update to the Council of Governors about the development of the ICS, and Vicky Taylor, who's right at the heart of that, and she is the ICS Director for Joined Up Care Derbyshire, has precisely 15-minute window in her diary today. And I think I'm already about 1 minute into her 15 minutes. So we're going to go straight to Vicky, who's going to talk us through a few slides and just tell us where things are at. And if you're very quick, you might get a question in. And then we'll let Vicky go to her next meeting, and then we'll go back and have a few more questions around the Chief Exec's update. So Vicky, the floor is yours.
Sorry, I'm on mute. Not a good start. So thank you very much for inviting me to the meeting today. I do have just a couple of slides I'll take you through, and I'm happy to answer them. I will take them away either for consideration or to come back with an answer. So, as asked about the establishment of the integrated care system in Derbyshire, the ICS, and our future governance arrangements and how this might impact governors. Could we have the next slide, please? Thank you. So, I'm sure colleagues are probably aware of some of this, but just in terms of perhaps some helpful context, just to remind ourselves the purpose and the outcomes that we're trying to achieve as an integrated care system. And that integrated care system is essentially a partnership of partners across the health and social care networks within Derby and Derbyshire. So that's what makes up Joined Up Care Derbyshire ICS. So our purpose is really, I think, as you would expect, for residents, citizens to have the best start in life, to live well, age well and die well. And the outcomes we are trying to achieve, which are very much aligned with both the city and the county health and wellbeing boards, are to improve life expectancy and healthy life expectancy for the people of Derby and Derbyshire. We are now officially an integrated care system, so no longer what was called an STP, and that is a reflection of the ever improving partnership working across sort of constituent partners in the system. So hopefully that's just a little bit of introduction by way of context about what Joined Up Care Derbyshire is and our aims and ambitions. In terms of thinking about governance and future of the ICS, I think important to highlight, and you're probably familiar with this, but NHS England and NHS Improvement recently published an engagement paper about the future of integrated care systems. And there was a really strong emphasis around the things I've listed here. So partnership working, which I've already mentioned, the development of strategic commissioning. So that's moving away from counting widgets, perhaps the easiest way to describe it, and really focusing on outcomes. But also a really strong focus on developing strategic provision. That strategic provision is really around collaborative working across provider organisations, and so that we can improve health and welfare of the population of Derby and Derbyshire. Next slide, please. So in terms of governance and essentially what that potentially implications for roles of governors moving forward, there are some significant implications if this engagement paper is enacted in April 2022, which is the proposal. So some of the key things it means is that Joined Up Care Derbyshire ICS will in fact become a statutory body, which is quite a significant change from where we are now. It means that the clinical commissioning group, so Derby and Derbyshire CCG statutory functions, will transfer directly into the ICS, and the CCG clinical commissioning group will not exist in the form it is currently. Other key developments will mean that there'll be strong provider collaboration at place and at scale, and these are both evolving, I think it's fair to say. So in terms of place, it's perhaps not the 8 places that you may be familiar with across Derby and Derbyshire. These places that are referred to nationally now are much bigger footprints, probably much more aligned to local authority boundaries. So that might lead to a suggestion, which is yet to be worked through, but could lead to a suggestion that in fact there'd be 2 places in Derbyshire, obviously Derby City and then Derbyshire County, but that work is currently being developed and led by one of the chief execs in the system, which is Tracy Allen, chief exec of DCHS. The timescales are clear. I've mentioned April 2022. There is a national expectation that all systems, so ICSs and STPs, are moving, transitioning to this new way of working now, not waiting until April 2022. And clearly that does have implications for our governance across the system. I think it is really important to highlight as well that there's no national blueprint for this. There isn't an instruction card that tells us exactly how to do this. There is a lot of local determination about how we develop this within a national framework, clearly, but it's down to local determination, and clearly it will be an iterative process. So there is a really great opportunity for governor colleagues and broader partners to get more involved in helping to shape this over the coming months and coming year. Which I think is a really important point. And I think one of the other things that's very important, which you might want to think about in terms of your input to Chesterfield Royal Hospital, is that individual organisations, particularly NHS organisations, are now being asked to consider how they need to change in response to the things I've just described as we move forward. So are there opportunities to streamline internal governance, to reduce duplication as we move much more to a system way of working? And as I've said, there isn't a set way to do this. These are things we need to think about, explore and work through a way that we can do this safely, effectively, and importantly efficiently as well, so we're not having that duplication. Next slide please. So I'm not planning to go through this, but more than happy for the slides to be shared afterwards if helpful. In terms of how we move to this new way of working, the Joined Up Care Derbyshire Board has agreed an interim governance, which is highlighted here, and really just to say that the focus is very much around building, you see above the dotted line in the middle of the page, a focus around strategy and particularly system assurance. And many of these groups will be led by non-exec directors and indeed chairs of organisations to ensure that we're getting a system perspective on assurance about our delivery and how effectively we're working. Below the line is very much around implementation and delivery, and is that executive function. Next slide please. Thank you. So in terms of thinking about what it means for governors, I think that, it's very clear that we welcome the opportunity to think about how governors can support this transition and beyond. I think it's also clear that you're an untapped resource in the system, clearly significant contributions in respective organisations, but there may be opportunities to have much stronger involvement in the system space. John McDonald, the chair of the ICS, and myself met with a number of lead governors last week from across partner organisations, just to start some discussions around the opportunities for governors to be more involved in the ICS as it develops. And there were some emergent thoughts which I've just listed here. We did talk about strong connectivity with place, and whether there may be opportunities for governors to link with the places as they evolve and use some of their local knowledge, community knowledge and expertise to input and influence the development of place. We also some of the governors talked about walking in each other's shoes. I think was the description used about learning about what's happening in other organisations and other partners across the system. We did also talk about whether there's benefit in governors supporting the governance structure, the interim structure. I think there was a general sense that perhaps wasn't best use of governors' time or expertise, but that was thoughts from a small group of governors. So again, that might be an opportunity if colleagues felt that. And I think really I will finish there by saying clearly I'm happy to take any questions, would welcome your views either now or in the future around any opportunities for governors to link more closely in terms of the evolving ICS. Thank you.
Thank you very much, Vicky. That was super. And we were very diligent about giving updates to Council of Governors about, the business of Joined Up Care Derbyshire Board, but really helpful to have it all set out kind of almost from first principles. And so clearly from your perspective, being at the heart of putting the new arrangements in place. So given the pressure that's on your time today, it's kind of you to find the time to join us. We completely understand if you need to dial off, but just to say to governors that obviously Angie and I and Lee are members of the Joined Up Care Derbyshire board and arrangements. So, it's not as if you won't have an opportunity to ask questions on the back of that, because we'll do our best to answer them. And I'm assuming, Vicky, you need to dial off. So thank you very much for coming.
Thank you. Thanks, Helen.
Now, just in the interest of not making governors completely dizzy with us moving with alacrity up and down the agenda items, why don't we just stick with the presentation that you've heard on Joined Up Care Derbyshire from Vicky? And if there are any questions you would like to ask on the back of that, please feel free to do so, and we'll do our best to answer them. Jeremy.
Thank you, and I think Vicky's still there, so thank you, Vicky. In past years, the link between local government and the NHS was through health and wellbeing boards. What's happening to them?
They're alive and well, and they're meeting, and they're a really important place where the overview of social care is taking place. And we've a really good relationship with both the city and the county through Helen Jones and Andy, whose surname escapes me, but Angie will remind me. Smith, who represent the council and the council's responsibilities at Joined Up Care Derbyshire. And I can't praise enough their contribution. They're really active, and there's no, at the beginning of this, I suppose it was kind of a period of transition, but it's really modern and proactive and engaging thinking that's coming from the council about how it is we link in from the social care agenda into the health agenda. So I feel there's kind of good cross-referencing, and indeed the arrangements are much better and more streamlined, because initially we used to all kind of turn up to one and then all turn up to the other, and we're having difficulty kind of honing the business. But I think that kind of that strong liaison between local government and Joined Up Care Derbyshire, and them able to bring that back into the Health and Wellbeing Board is, short of us having a perfectly seamless integrated health and social care system, which none of us would say we're kind of there. There's good inroads being made to get better integration and join up.
It seems to me there's a danger that JUCD board and the Health and Wellbeing Board are going to be basically covering the same territory. Is that a misunderstanding? And if I'm right, how's that being mitigated?
Vicky, it looks like you're still on the call. If you are, would you like to comment?
Thanks, Helen, and yes, I'm more than happy to comment on that. So I think that's a really good challenge. One of the things that we are exploring between Joined Up Care Derbyshire and also the Health and Wellbeing Board is what's the common ground, the common interest and priorities that we have, and then and that's linked to our earlier priorities that I mentioned, the improving life expectancy and healthy life expectancy, and then also working through what's our respective contribution to trying to address each of those areas. So making sure that we're not duplicating effort and time, but actually saying what is Joined Up Care Derbyshire's contribution, what is the Health and Wellbeing Board's contribution, and I think both parties are really mindful that we need to do that piece of work over the coming coming 2 months, I think, and there are some workshops planned for us to be able to hopefully work that through. So hopefully that gives you some assurance.
Thank you.
Norman. Norman, you appear to be off mute, but we can't hear you. Try again. No, can't hear you. Can other people hear Norman? No, no. Sorry, Norman. You might want to dial out and dial back in again. Sometimes it's a bit like, you know, turning off the computer trick. We'll come back to your point, Norman, when we get the sound. Particularly as we have Vicky on the call for a bit longer than I anticipated, are there any questions anybody would like to put to her while we've got her? No, other than Norman. Have one last go, Norman. Oh, joy. No. Okay. Well, Vicky, don't take you know, the fact that there isn't a flood of questions as any sign of disinterest. I like to think, as I say, and Vicky will have heard me say there's a joint up Care Derbyshire meetings when there's questions about, you know, how will the governors and the board come with these new arrangements and what will the feeling be? And I always say the only feeling there is at Chesterfield is impatience, because our desire is to put the patient first, not any organisational niceties or arrangements. And, you know, if joining up across the system is the best way to get the best possible patient care, well, we're all for it. And let's hurry up and do just that. You know, I think what you're witnessing today, Vicky, is hopefully a well-briefed Council of Governors, you know, who wish you every success and speed in, you know, making the final steps in the transition to fully fledged statutory ICS status. So thank you very much for joining us. Very grateful. Okay.
Thank you.
So if I may, we're going to go back, Angie, and then I promise to stop skipping around the agenda to Angie's update. So you just answered that question very comprehensively that we'd had from Norman about other hospital business. The one I'd like to go to now was from Mike Grundman, and it was about, I think it was from Mike, and it was about lateral flow testing. And the kind of question was, how reliable is it? And is it a good means of us containing any hospital-acquired infections? And how do we get the results? And how are they communicated? And how does that inform the decisions we make about how it is we deploy people? And do we have any concerns about the robustness of that as a test in terms of doing what it's designed to do in terms of hospital staff? All of that sort of stuff.
Thanks, Helen. And rather than everybody listening to me all the time, I'll ask Zoe, as she's led the work on lateral flow testing for the Trust, to come in and just give us an overview. And then Hal, I'm sure, will want to comment on reliability and how we use it. So Zoe, do you just want to give us the overview of our rollout?
Yeah, I can do. Thanks, Angie. So governors will know, I'm sure, that we're at the point where we've been able to offer lateral flow tests to everybody in the organisation. So from a rollout point of view, we started with patient-facing staff, and then we've rolled that out to everybody. They're obviously not 100% reliable, and we don't see them as such. So if somebody tests positive with a lateral flow, they need to isolate and then have the PCR test, which is the lab-based test, and it's at that point it confirms whether they are a COVID positive or COVID negative, rather than at the lateral flow test. The lateral flow test does trigger the isolation point, however, so in terms of movement around the hospital, for example, that would be a trigger for people to stay at home effectively and isolate whilst awaiting the test. The way the kind of results are captured, an individual either texts or emails, most people text, I think, and that feeds into sort of the database, and we do monitor in terms of how many results there are. So people do it twice a week, how many results there are coming in, how many of those are positive, how many are negative, and how many are invalid, which is a small number of the invalids. and then that translates through to how many then test positive in terms of the PCR. And I should expect there are returns around submitting this data up to the region, and then that goes up nationally. So that's the way it works. Initially, all trusts received a 12-week supply for members of staff. We started this in November, so we're at the point now where we're coming to the sort of the tail end of the 12 weeks. At the moment, we're waiting to hear nationally what happens next, whether we will be issued with another set of so many weeks or whether it's something different. So for now, we're carrying on with that and are waiting to see what happens next, effectively.
Did you want me to come in, Angie, regarding the sort of accuracy and sensitivity and so on?
Yeah, I've just asked you to come in, except I was on mute. Apologies, Hal. That'd be great.
So governors and non-execs will know that there's been lots of debate, including, in the national news and so on, about the sensitivity and the specificity of lateral flow testing. I think we have to consider it as part of an armoury about trying to drive down transmission rates rather than it being 100% accurate. Apart from anything else, it depends on the staff members themselves doing it properly and regularly and so on. Governors will have probably seen in the last couple of days there's been stuff on the national news about the fact that actually lateral flow testing is probably better than we thought at picking up those people with high levels of active antigen, so high levels of active coronavirus. Those are the people who are, we believe, the most likely to be the most infectious ones. And so by picking up those people who are most infectious, there's an increasing school of thought that actually this is a useful thing to do. So that whilst it's not as sensitive, so it's not, it doesn't pick up quite so many people as a PCR test would be, it is picking up those people who are likely to be the most infectious and therefore, from a staff point of view, are most likely to be then spreading the condition in the hospital when they come into work. So if we think about it, if a staff member is checking their lateral flow testing and it's positive that morning, that means they don't come into work because they potentially might be infecting people. Whereas if they were doing a PCR test in the morning, they wouldn't get the result back until 4 or 6 hours later, even if you had the most efficient system in the world, by which time they'd have been in work all day and they might have infected lots of people. So I think we have to consider it as part of the armoury. It's not perfect, but I think it does have some added benefit from the point of view of general transmission, but most particularly for our patients and staff colleagues in the hospital.
Thanks very much, Hal. That's a very helpful perspective. And the last one I'd like to raise from the Governor pre-meeting was from Ruth, and it was in 2 parts, and we'll do the COVID part first. We're aware that we have difficulty with ED COVID results. So somebody comes to ED, they have a test, and getting that test communicated in a timely way so that it mitigates against any spread of the infection. Ruth's point was a slightly equal but opposite version of that, where she'd referred a patient and I think the story, Ruth, was that they were considered by ED to be COVID positive but hadn't had a test, and there was no communication back to Ruth in the practice about the likely risk to them having had this patient in the consulting suite for half an hour, whatever it was that morning. So I think just a kind of general concern about COVID testing on presentation or not, and the communication thereafter, either to the hospital or beyond.
And I know Berenice picked up a couple of examples that members gave us last week, so she was following that up, and there has been 1 or 2 where we haven't got that right, I know, so we'll make sure that we continue to follow up that process. I don't know whether you want to add anything, Al.
I don't know if there was individual cases where it didn't work, but in general, at the point people come to ED, if there's a prospect of them being admitted, they all get swabbed now. And those, from a GP's perspective, those swab results are then on ice. So it is possible so whilst we may have failed to communicate it, and for that I apologise if we've not got a good system with that, it is possible for the GP to access the result on ice if the swab has been done.
Okay, well, we leave Ruth to pick up the particulars of that out with here, but I think the general point is one that we'll want to be mindful of. And Ruth's other point was about IT. And I know you've quite a glint in your eye in terms of your ambition for taking IT further into the 21st century with each passing month, Angie. But the specifics raised were around Wi-Fi, access and reliability, but also our VPN network, in that it's not really a VPN network, is it? In that it's not pushing updates, or you can't pull an update and you're being reliant on coming back into the trust. And given that, you know, these ways of working might be desirable beyond the point when they're necessary, is that a glint in your eye as part of the general IT modernisation?
It's more than a glint, and my HLT colleagues will testify, as will Lee this morning, as we've caught up again around IT. So yes, Ruth, it's not where we need it to be, and COVID and the ways of working at the moment has really shone a light on some of the issues we've got, both technical and operational, but also that digital way of delivering healthcare for our patients. So we're on it. It will never be as quick as we'd all like it to be. And there's a discussion that Lee and I are having with board colleagues next week around where we're at with that programme, and we'll put some brief messages around that so everyone's up to speed with the work that we're doing. I don't really want to add anything there, Lee.
I think that's fair, Angie. I think there's a very specific problem with the Wi-Fi at the moment. It's got a load that we never anticipated, and it's coming towards the end of its useful life and is scheduled for replacement next year. So that's a very specific thing on the Wi-Fi. I think more generally, the demand into IT services, because of remote working and remote consultations and a range of other things, has grown enormously over the last year. And I think the honest answer is we haven't kept pace on the resourcing side, which we are hoping to remedy imminently. Not that we've got a magic money tree, but I think there's an absolute acknowledgement that we're going to have to do something different to keep pace with the digital requirements.
Thanks very much, Lee. So I think we leave it there. I'll give you the full list of issues raised at the irrelevant slot, but they were the ones that really played into your update. And just before we move on up Angie's update, are there any other questions that people have?
Yeah, Helen.
David.
I'd like to hear Angie's comments on my point concerning COVID deniers and interference with hospitals.
Yeah, very good. We tackled some of this in the pre-meeting, Angie. It was David's point about his knowledge of some trusts, particularly in the south of England, where they're getting protesters. And I have explained that people up north seem to have more sense, but that Sarah had been very vigilant in drawing it to colleagues' attention to be mindful and alert. So we've covered it to that extent, but if there's anything you'd like to add.
Just to say that we are continuing to be alert, and I had a very, I would say, entertaining conversation with a member of the public on Friday, who was one of those. So we will respond in all ways that we need to keep our staff and patients safe while managing their concerns. And I think the other way is being proactive with our messages around how we're getting out there the experiences of our staff. So board members will be aware we potentially have got the media supporting us with some of our experience and telling our story, and that's how it's certainly helped in the south of the country and nationally, both for our staff to be able to say what it's like, but also to really get that hopefully message across. We'll never get it across to everyone, will we? But that very real message, and hopefully with that local flavour from our staff will help that.
Yes. Okay.
Pervez.
I have a question with regard to mortality, and perhaps Hall or Angie or both of them, they may make certain comments. One of the major determinants of mortality is accuracy of coding. I would like reassurance that enough work is being done to improve the quality of our coding.
So for those who couldn't hear that, the question is around mortality, the rate of mortality and the contribution or otherwise of the accuracy of coding to the reporting of mortality. Would you like Hal to come in on this, Andy?
Please, Hal, yeah.
Thank you, Pervez. But Pervez will know to a degree that he and I over the years have been quite involved in looking at the accuracy of coding in order to make sure that we were accurately capturing all of the comorbidity that patients may have. And the reason for that from a clinical care point of view is to make sure that we're considering all of the different conditions that a patient might have from the point of view of making sure we're optimizing their care. From a mortality point of view, the comorbidity, so the other medical conditions that patients have, impacts on the statistical likelihood of someone dying. So a patient who's 90 years old, who has diabetes and previous heart problems and lung disease is more likely to die than someone who is 25 and otherwise fit and well. So from the point of view of the national mortality figures such as SMR and the SHIMI data, if we don't capture that data correctly, then we risk our mortality figures looking worse than they indeed are. I know Carson's team and the coding team do work really hard about that, and I know that when there is I can't quite remember the technical details of how it works, but like all these things, there are some KPIs for coders regarding the depth of the coding, which is also captured in the SHIMI data. And when we compare ourselves to other organisations, if anything, we are kind of better than average from the point of view of capturing that comorbidity. But I know it is something that is under active ongoing review. I know we have clinician involvement supporting the coders to do that. So one of our consultants, Nora, is involved with that. And we will continue to do that because you're absolutely right, Pervez. It is an important thing that we consider and keep looking at.
Thank you very much. So if that's the totality of the questions in Angie's report, let us thank you for it again, Angie, not only for the comprehensiveness of the report, but for the insight it's giving us into the extent to which the hospital is not only coping with COVID, but doing an excellent job in trying to keep other services going throughout this period. So please convey the thanks of the Council of Governors to colleagues for that. That brings us to the next item, which is on success measures. We had a bit of a debate about having this report at this meeting, but we decided, frankly, we couldn't very well not have it because it would be a bit concerning for governors, wouldn't it, if they thought that NEDs were not across their brief and responsibilities in terms of being able to account for the performance of the trust at this important time. But we have gone for a slightly less paper-heavy approach, and NEDs have tried to be pithy in the reporting. But we're going to now go around the table in the kind of time-honoured tradition in order to give you a kind of update. And as we said when we discussed this, it's going to be as revealing to governors those areas where we're not focusing as those areas where we are, because by implication you'll get a flavour of where it is we've had to put focus and priority. So I wonder if I could ask, please, for Alison to lead off.
Thanks, Helen. The area that I look after is restoration and recovery, and Really, the only thing that I can add to what you've already heard is to give assurance that it is discussed through finance and performance and at each board meeting and at our regular NED catch-ups with Angie on a Wednesday. As you've already heard today, it's a constantly evolving and changing situation, and I can only commend the efforts of the execs to you in terms of reacting and responding to the developing situation and trying to balance both dealing with the COVID pandemic but trying to maintain other services as well. And you've heard lots about that today. So it's very difficult to comment on individual performance because it's changing all the time. From the figures today, I think we're 40% of the bed base is COVID at the moment, and I think Angie's alluded to the forecasting says that we should have reached our peak, and that we should be at peak for the next 2 weeks, and then starting to reduce. But that reduction seems to be going more slowly than we might have hoped for. So it really is a developing situation. But just wanted to give assurance that it is being monitored on a weekly basis and through all the formal meetings that you would expect. And finance and performance is keeping an eye on all of that conversation. In addition to performance, we also keep an eye on finances, and that has been a changing situation over the months. And we're now starting to turn our focus to planning for next year. And that's within the remit of Joined Up Care Derbyshire. And I think the other part that finance and performance have been paying attention to is to lessons learned from COVID and how that has influenced our thinking on the urgent care village. And the last 2 finance and performance meetings, we've had the business case revisited for urgent care village and the plans to change what we were going to do. We're still going through some of the design phase and absolutely the financial planning phase. But again, for governors, that project has been reviewed, and we're now going to change the design and not just reconfigure the current footprint, but add additional space into the urgent care village design. I think that's all I can update on. Angie, is there anything that you would add to that update?
No, perfect, Alison, thank you.
Okay, so happy to take any questions.
Thanks, Alison. I'm not going to pause for questions after each. I think we'll just do the report and then we'll come back and then governors can ask questions in the round. But thank you for that offer. I'm going to move to Jane next, please, for the update around patient experience and quality, please.
Okay, thank you, Helen. So I've provided you with quite a lot of information in the report, but I just want to concentrate particularly on 3 things verbally this afternoon. So one would be governance, because it's really important that our assurance committees are based on firm foundations. So we have taken an opportunity with the new starting of Krishna and the new working relationship between Krishna and Hal to think about quality and the reporting through to our committee, but also thinking about divisional assurance meetings, how they carried out, what their focus is, and also how they connect to the Quality Assurance Committee. We've also had a 360 assurance review, our annual review, and that's found that we have very good firm foundations already for QAC. So we haven't done this kind of navel gazing in the spirit of there are things that we wanted to fix, but really in the spirit of actually wanting to improve. So that's really about making sure that the Quality Assurance Committee is focused on the right things, and our divisional assurance committees are focused on the right things, and those things dovetail together. In terms of patient experience directly, we have an aspiration as a board, and this we have discussed as a board, the need to really move our patient experience into a bit of a different direction in terms of thinking about innovation. So we have lots of metrics around friends and family tests and surveys, etc. But what we really want to do is try and focus on getting real-time patient feedback so that actually we can really, really quickly respond to what our patients are telling us. So that's been a bit of a challenge, and we're expecting a report back to March board on that. So just to think about that in a slightly more innovative and probably, dare I say, digital way than we currently do. So that was really just about governance, really, just to sort of tell you that we are thinking about our assurance processes. The next two things I want to just highlight are stroke and maternity care. So stroke, we've just had a little conversation about that in the informal meeting, but just to say in public meeting that we do have an action plan in place for stroke improvement, and that's a very detailed action plan, and we are very keen to see some improvement around the key metrics around the stroke pathway. And again, that's been reported through QAC, and it's also being carried forward through oversight of the board as well. And I guess I probably should say that obviously at pre-meeting we were discussing the leadership of the stroke unit as well. Really, we've had lots of work that's been ongoing since December, when the interim Ockenden report into maternity care was published, and that's the report many of you will recognise about maternity care specifically at Shrewsbury. And there was a massive piece of assurance work that our teams needed to undertake around 7 key and immediate actions that we needed to review. And we met on the 11th of January as a deep dive meeting of Quality Assurance Committee, just to look at those assurances that were being provided to the system and to NHS improvement. And actually we really scrutinised all the evidence that had been put forward. I think the thing to say about Ockenden is the thing that probably is most disturbing is the fact that there was a total lack of kindness and compassion in the care that was given to those women. And actually, what do we know about our care here at Chesterfield? And we've got lots of information firsthand from our mothers and families, but we've also got recent CQC inspection, which actually did make remark on the kindness and compassion that's provided. So I think, we have to think about this not only just in terms of what Ockenden was asking us, but also in terms of our other intelligence. So I'm really pleased to say we've submitted that assurance as we were requested to do. We are continuing to think about the visibility of maternity, and again, you've heard me say previously that QAC was keen to make sure that maternity care was really visible to us and to the board, and of course to you as governors. So you'll see as well that through the IPR we will be providing now the key maternity metrics, so that we can all have visibility of those on a monthly basis as well. So I think there's lots to be proud of in terms of our maternity care. As I say, we've provided lots of assurance. We have got other information that tells us about the quality of the service, but we're also going to have the monthly safety champions meetings, as we're required to do again by Ockenden. And we've got 2 board champions. We have to have an executive and a non-executive board champion for that. So those roles are taken by Krishna and myself. So with that, I'll defer to questions at the end of the meeting, or at the end of the item, and just ask Krishna if there's anything else that she wanted to add from the narrative that we've provided.
No, Jane, I think you've covered it really well. Thank you.
Thank you.
I'll answer any questions at the end.
And again, thanks very much, Jane. A great indication of the extent to which Quality Committee are all over business in a helpful and sensitive and proportionate way at this time. So thank you. I'd like to go next, please, to Sue.
Good afternoon, everybody. Thank you, Helen. So I put quite a bit of detail into the report, so I'm not proposing to just read it out or pull out any of that information from there. Happy to take questions, but I just wanted to give a few extra updates. Had been catching up with Maria Riley, who is ever as energetic as she ever has been about all of this lovely stuff that the Royal Academy of Improvement is leading for. And I know we've got Luke on the call, so I'm sure he'll keep me right if I get anything wrong. So just a few points really to point out, which I think are very good evidence of the developmental work that the team are doing. It would be really easy to focus on only the firefighting, the here and now, and I think what the work that they're doing is a really great blend of dealing with things that come up and dealing with them quickly, as well as doing that horizon scanning and the foundational future stuff that we must keep an eye on, because it will all still be there when this is over. So I must congratulate them, because I think that's a really difficult balance to achieve. So just a couple of things to point out.
you may have spotted our very own Hal on social media, and one of the things that the team have driven on is the videos that were put out, the kind of patient assurance videos, to give patients the comfort and confidence that they could safely come to the hospital for the treatments that they need, regardless of COVID. So I'm hoping that governors may have seen them, because they were spread pretty far and wide on social media, but I thought they were fabulous. And I think just an important point about the ability for the team to move quickly is they spotted a problem on the lung referrals volumes going down and thought that, you know, what's that about? And it would be sensible to assume it's for people with respiratory problems, might be nervous about going to the doctor or coming to the hospital, thinking it might be, you know, there might be a COVID case. So as a result of that, they've just done a video on lung referrals, which is about to go out, which is just a great example of how we can respond quickly. And the second point I just wanted to call out, in the paper I mentioned the Patient Hub programme, which I think is fab thing, the Patient Hub, having had a good nosy around it. And just to say, I didn't mention it in the paper, but we've got really good positive feedback from patients on that. For example, you know, in helping them helping them from not missing future appointments. And in the paper, I can't remember if I mentioned it or not, but we were nominated for an award. Anyway, we won it. Say we, you know, obviously I want to take the credit. The team won it, it was the Healthcare IT Award for the Patient Hub, which is brilliant. And, you know, they were up against some stiff competition. So a whoop for the team involved in all of that, and a well done. On the video consultations, which I also mentioned, I think just also worth expanding on that a bit of the stuff that's in the paper. So the project aim is for all services to offer that type of appointment where it's clinically appropriate, and just to say that that's increasing. So you know, including urology, breast, trauma, orthopaedics, and so on. And again, really great feedback from patients about that, rating their experiences very good or good. And obviously, you know, with COVID, it really pushed us, didn't it, into doing that and doing that quickly. But I think that, you know, it will carry on. It's one of those things that we need to make sure we keep hold on. So the team are tracking how that's working, what the virtual appointments are, and what the uptake is and how that's working. And one of the things about the video consultations is, you know, there might be people who think, well, it's not such a great idea, I prefer to be face-to-face, or I prefer telephone. So again, the team have put together a video just to really sell the benefits of a video consultation, which is to get other clinicians in the hospital thinking about how they might use it, so that patients themselves can see the added value. And also the feedback we're getting from the primary care clinicians is that they really love the video consultation. So they're tagging the link to the video on their websites, and that I think would be a great one to share with governors. It's perhaps something we can send to governors after this meeting. It made me weep a bit, so just to warn you, if you're like me in a COVID world, a bit easy to cry. The video might make you weep, because I think it's lovely. And those I think are also really good examples. You know, we've just heard from Angie, and I understand entirely our concern and our passion and ambition to get our digital capability stronger, but it's just to give some examples that we are doing loads of good things still in this digital space. I wouldn't want governors to think that we are idling. So a fabulous example that I only really found out about today in discussion with Maria is the planning to run a COVID virtual ward. I.e., you know, if I was really thinking of, the thing I love about this is it's so patient focused, because if you're a patient, you know, you're at the end of the illness, but you're still on oxygen, but you know, you don't need care other than to be checked over each day. You can be discharged and monitored from home on a daily basis. And the team have kind of galvanised to do that really quickly and want to start that from next week. And then just to test how that works and how that impacts. And of course, for the patient, it means they can go home, be in the safety and comfort of their own home. And of course, for us, it also means it's not a patient in a bed, so it's a double whammy. And the other point I just wanted to reference, because it's certainly relevant to me with my elderly mother. The great thing about the Attend Anywhere digital solution that the team have come up with is it means family members can join from anywhere, so you don't have to be present in the room, which I just think is another really patient-focused bit of digital goodness. And then just the final point, because I don't mention it so much in the paper, is around our cancer pathways and an initiative around the breast pain pathway. that the team have been working on. I think learning from Nottingham, who'd already progressed this, and working with Derby to do a Derbyshire pathway. So instead of going into the kind of the 2-week referral process for breast pain, which could potentially cause unnecessary anxiety and testing for patient, to develop a pathway, breast pain pathway for non-urgent referrals. So again, it's just another example. I think everything I'm reading about is very patient focused, is very much about how do we make things smarter from a digital perspective where we can, how we respond to things that are not working, you know, in the short term and deal with that quickly. But also really great examples of system working with Joined Up Care Derbyshire and so on to really maintain our capability and keep that constant improvement. So I would say governors can be very assured and that great work is carrying on. And the team, I think, have adjusted really well to virtual ways of working, you know, the virtual training of the cohorts for QSA and so on. So loads of good examples of adaptability, but delivering real sustainable change for the hospital and for its patients. So I'll stop and take any questions later. I'm sure I might defer to Luke if I get stuck.
Thank you very much, Sue. Sense of the substance of what's going on and a bit of colour about how the team are coping. So thank you for that. I'd like to move next, please, to Keith and the whole issues of Royal Primary Care. If you're on the call, Keith.
I am. Sorry, you paused as if you were going to say something else, Helen. Sorry, I was waiting.
I'll tell you what was in my head. I'm conscious that we haven't dealt with Kate's question that she brought up in the informal meeting about the general issue about our ability to liaise well between primary and secondary care. And I thought I was going to invite a comment from you on that in real time, and then I thought, oh, that's probably not fair. But as you identify the pregnant pause, if you feel moved, a comment now be good, or failing that, we'll go back to colleagues after the meeting.
Yes, I'm conscious also, Helen, in response to that Berenice is not here today. So from an exec point of view, I can't get a direct response to that. I think it is a comment that has has alignment with other comments that have been made in the past, if that makes sense about that. And I think also about access into the service sometimes and issues around that. And my suggestion, rather than me giving a slightly ill-informed response, is that I take that away. If you're happy, on behalf of Katie and the governors, I'll talk to Berenice when I think she's on holiday this week, isn't she, Angie? And I will come back with a written response. I think that would be more pertinent if you're happy with that, Helen.
Yeah. Hence the pregnant pause.
Well, no, I like to look for these things. Royal Primary Care, I've put a few short bullet points in at the moment. I think the real focus, you'll remember that the latter part of last year, we brought the 5-year forward strategy for RPC through to the board and through to governors, and took that past all of you. Clearly, at a time at the moment when the focus for Royal Primary Care is very much on twofold. It's very much on managing the care for their patients that they need to with existing needs, also while delivering or being part of the delivery of the largest vaccination programme that this country has ever delivered. So I think we need to be conscious of the amount of spare capacity and work that there is at the moment to do things beyond particularly the second of those and the vaccination programme. However, you'll remember that the early part of that 5-year strategy was around a number of things, and it was around really focusing on the governance of RPC in relation to Chesterfield and how that works and how that could, I think, in fairness, better work in the future than it may have done in the past, and finding the right structure and the right controls and the right operating model for Royal Primary Care, working with Chesterfield and gaining the benefits of Chesterfield and the size and scale of Chesterfield, but without creating an environment that prevented RPC from being able to do what it needs to do. And the second element of that was around the way that RPC is able to work and interact with Chesterfield. So, you know, how standalone is it? How part of of Chesterfield is it? And what's the best model going forward for RPC to be able to deliver the services that we want, and that to work in conjunction with delivering great services into Chesterfield and working together as a partnership. Those conversations are going on aside of the COVID and the vaccination programme. Angie and Berenice and Peter and his team are working through those. I think there are some quite meaty issues in there, and they're not necessarily easily resolved. And given the time constraints on both organisations at the moment, I think that is going to take longer than we initially anticipated when we wrote the plan in the midway through last year, when things from a COVID perspective perhaps look slightly shinier than they do currently. So there is a huge piece of work around that, and that will continue. And though that's the fundamental kind of bricks, if you like, to allow RPC then to really start to deliver as part of Chesterfield and have the right controls and the right structure around it to be able to deliver forward. I think, Helen, that's probably all I'll say, but I will come back to the broader questions that have kind of been asked both today and perhaps previously with Berenice when she's back.
Thanks very much, Keith. Jeremy, the whole of the kind of people agenda, please.
Okay, thank you. I don't have a huge amount to add to the bullet points in the written report. Zoe and I have been in correspondence just over the last 24 hours about the agenda for the next People Committee meeting, and in light of the fact that there are more important things to be doing, she's taken a big red pen to the agenda, and I've then put another big red pen through most of the rest of the agenda, so we're going to have a fairly slimmed down meeting on the 24th of February. But the main concern at the moment obviously is twofold. One is staff well-being, and the other is staffing numbers, so we'll be concentrating on those two elements. Just on the staff well-being point, there's reference in the report there to the significant amount of money that's being made available for CPD, and Andy Picken, who's the health and wellbeing lead, has been quite imaginative, shall we say, in putting together a proposal to use some of that money to pay for some of the staff wellbeing initiatives on the ground that staff wellbeing is important for their continuing professional development, which I'm sure we'd all agree with. The other couple of things to note are that in spite of everything that's going on, essential training compliance has been maintained at really remarkably high levels. It's not quite at the target of 90%, but I think the fact that it's stayed up in the mid 80s is very impressive anyway, all things considered. And the other big thing that's going on in the background is finally we're going to be adopting ESR, which is the person management system. And that will mean we are no longer going to be the only trust in the country that doesn't run on ESR, which will have some benefits. And it means everybody's going to get paid a week early in March as well. So if there are any questions, I'm happy to take them later. I don't know if Zoe wants to add anything to that before we move on.
No, thanks, Jeremy. Just to say, and that'll be a big hooray when we finally get ESR. Come off the list of being the only one that doesn't. Thanks, Jeremy.
Thank you both. Atul, please.
Thank you, Helen. And as I've said before on this item, it's a bit of a compendium where innovation is something that cuts across a lot of things that we do. And you've heard from other NED colleagues, Jane and Sue, for example, how innovation is faring in their areas. A big aspect of this is, of course, how the ICS is getting up and running and settling down. We've had a pretty full item on that at today's meeting. The only thing I would add to what's in the report is to just say, as we sort of segue into our next 5-year strategy, that we're going to need to apply innovation to the NHS of the future. And I do hope that within the ICS there's going to be enough time and space to think about issues at that kind of level. Obviously, at the moment, COVID is consuming everything that we do, but we will be beyond that. I think we have to remain optimistic about that. There are every sign that that will be behind us at some stage in the future, and then there's this whole world of integrated care and how we're going to actually work together properly, rather than it becoming just another layer of operational oversight. So I think that's what we've got to look forward to and focus on. But generally, in terms of innovation, are obviously working together within the system. Other reports that you've had today really do give you a flavour of the fact that we're having to innovate at all levels.
Thank you very much, Atul. Mike, can we pick up procurement, please?
Yes, we certainly can. Afternoon, everybody. As you're probably aware or remember that my project was to make sure that our procurement function did its best to comply with the national accreditation standards. A couple of meetings ago, we reported that we delivered the first of those accreditation standards through the hard work that the procurement guys had done. I also reported that the second standard we were aiming to get was one that would involve embedding procurement standards across the hospital, and was something that was outside of the gift of just the procurement guys. Clearly, we've not been able to push that as farther forward as we would have liked in the environment, and we've kind of had to park some of those specific accreditation developments. I do my weekly call with Dennis every week, and he's still on top of the procurement situation. The update in the report talks about the three things that we're focusing on, which is making sure we've got supplies appropriate to the pandemic needs, that we've got sort of flexibility of staff around what's going on in the pandemic, and that we've got and that we've got the commitment to deliver the NHS's net zero plan ambition. So they're the three things that we're currently focusing on. We haven't and we will not lose sight of the national accreditation standards, but it's one for the future, particularly given that the procurement towers that Lee refers to in some of his dialogue has been put on hold. So I think you're going to get the same update from me for quite a while now until we get through the pandemic. We can only go to these accreditations once every year anyway, so we would have had a lapse after accreditation 1 till we could formally apply for accreditation 2. But the guys are still doing their best, making sure that we've got plenty of procurement for pandemic. So there's no burning platform, but the development stuff that we hope to put into the hospital is going to have to be parked just for a little while. Lee, does that make sense? Anything you need to add?
It made perfect sense to me, but to be brutally frank, Mike, I'm a bit appraised of the agenda, but there's a sensible, we can't quite do level 2 because a lot of the operational staff are a bit focused on other things. It's a rate limiting step, but it's off the agenda, but we need to pick the right time to bring it back. All fair, Mike, and I'll shut the hell up.
Yeah, absolutely. As I say, I spoke to Dennis today. He's doing other stuff. I mean, Dennis is all over the IT situation that Angie mentioned, and I've even been told today that we have some of our finance team helping on the catering and cleaning side. So he will remain flexible, and the procurement will just be part of that flexibility as life hopefully resolves some way back to normality, whatever that might be.
Thanks very much, Mike. Helpful update. And last but by no means least, the second tour of duty from Keith, this time on digital, please.
Thank you, Helen. I didn't know to pregnant pause that time, so I'll just carry straight on. Yes, so I'll talk about the detail in the report. I think there's a couple of things to mention. I'm conscious that the kind of EOBS project continues to roll out across the trust. I think I'll say the same thing that I've just said with Royal Primary Care, which we need to bear in mind the amount of work, reconfiguration and everything that's going on in relation to COVID, which doesn't make any of those pieces work more rapidly. I also noted Helen, we had a comment about Wi-Fi and access, and which we talked about in the pre-session and also a little earlier. I think Lee's response is very good. I think it's worth adding at this point that 18 months, 2 years ago, when anyone sat down to do the plans that they would have done, nobody envisaged the need or the level of remote working and system strain that COVID would have introduced into the system. So I think Lee and the IT team have responded and as rapidly as possible, but I think there is a need for more resource and more capability, and that is coming, but it is always going to be behind the curve when you start late, and it's worth just saying that. I think the system actually and the trust is holding up very well in comparison with others who don't even have the flexibility that we have. I think the biggest piece for me around working as a joined up system, and we talked a lot about that earlier with Vicky, has been probably the Derbyshire Share Care Record, which we first started talking about now for as part of Joined Up Care Derbyshire back in kind of April-May time, and we will go live next month in March with a Joined Up Care shared record, or the start of it, across the whole of Derbyshire. So in less than a year, the team have pulled together that entire capability, delivered, gone out to procurement, found an appropriate supplier, and are just about to go to proof of concept testing starting next month. Chesterfield's been very heavily involved in that. We are the contracting authority, which means we need to be. Stephen from procurement, Lee from a finance point of view, and also John Court from a clinical point of view, even given his huge workload at the moment, has been hugely involved in that process. And it's had great involvement from all the other providers, local authority, social services, and everyone else who's involved in that. So it continues to be a massive step forward for not only for Chesterfield but for all of Derbyshire, and I have to give a massive thanks to all the people involved in that, because it's for none of them is it their day job, and they've done that with everything else going on in the system at the moment. So I think that's probably the biggest piece that Chesterfield is playing in at the moment, and because we're the contracting authority, we're leading on that. But we will be effectively signing a 10-year agreement to deliver that now across the whole of Derbyshire, and there will be a series of projects, I think, that follow this, that will learn the lessons of the way this project's been run and how we can deliver that kind of joined up care approach to digital across all of Derbyshire.
Thank you very much, Keith. An exciting agenda, and as you say, quite a bit of progress despite other pressures. And I'm pleased it's such a patient-facing and patient-enhancing project that we've managed to prioritise. Now, to Governor colleagues, obviously, colleagues are happy to take questions on the detail of anything you've heard. I think it will be equally interesting to hear any questions or thoughts you might have about whether non-executive directors giving you that update against the priorities we set is making you more or less assured about, how things are at the hospital at the moment, and anything you'd like us to have an eye on going forward, or anything else you'd like us to do in terms of the reporting at this particularly tricky time. Floor is open. Have we caused you to be dazed and confused with the extent of the update? Mike, you're on mute, Mike. Still on mute, Mike. Nice message in Teams from Mike. Definitely more assured. Thank you for that.
Were you talking to me, Helen? I wasn't.
Yeah.
I hadn't raised a hand.
Oh, well, you have on my screen, but I have found a button that allows me to lower your hand. So, oh no, sorry. No, it's Margaret always turns up as Michael. So I was getting confused. Margaret, it's you. Sorry, Mike. And thanks for your comment in the chat.
I just wanted to say that I find the report that we've had, very useful and very reassuring. I'm going to talk in a little while about some things about arrangements in ICS, but it's one of the really good things is that measures of success are all tying in with more system working, and so that's really good. I'll say a bit more about that when I come to the next part of the agenda, but I just think it's working well as far as I'm concerned that we get these things, and it does reassure us that there are things that are happening other than the immediate dealing with COVID. There are still things progressing, albeit some of them may be a bit slower than they might have done otherwise, but it's very reassuring from my perspective.
Thank you very much for that, Margaret. Much appreciated. Well, it looks like colleagues are happy to note that report, so thank you very much. And that will move us on, if we may, to the system update, which you'll be pleased to know we've already had, and to the issue from the Governor's pre-meeting, many of which we've dealt with. Just for the sake of completeness and for the record, I'm going to just list off those that we're going to deal with outside of the meeting for the benefit of colleagues who didn't hear the earlier discussion. So Pervez raised some issues about stroke, our action plan, and in particular our capacity and capability to get the necessary leadership for the implementation of the action plan. Next, we had the item about lateral flow testing, which we've addressed earlier in the meeting. Frank gave us a very encouraging update about orthotics, which we were pleased to note. We've already commented on David's point about protesters and their activities in hospitals and our need to be vigilant and communicate well around that. The next item was from Norman about the percentage of other non-COVID work being carried out in the Trust, which Angie addressed as part of her report. Kate raised 2 points. One was a commendation for one of our clinicians, which I will have taken an action to pass on. And the other was the point we alluded to in Kate's update about RPC, where we're having difficulty getting appointments in primary care at a time that meets the kind of care plan requirements of the hospital consultant, which raises a load of issues about the interface between primary and secondary care, and specifically in this case between secondary and our own primary care. So an opportunity for us to look into that further. Margaret raised some very pertinent questions around the daily statistics we're getting and what the definitions that apply to these figures are, and not least of all due to the lack of comparability between stuff you read in the media, versions you see in other reports, and the version on the list. And we feel that there must be a lot of detail behind the definitions and the reporting requirements and timescales and geographies and all sorts of things. But I did explain to governors that we don't normally carry on with our lead meeting on a Wednesday, having had a COG opportunity to update together, but we'll have a brief one today for the purpose of looking at that very issue, and in particular with respect to hospital-acquired COVID admissions. But we will also maybe scope out an action at that point to think about the wider issue of definitions and comparability of data. So a big one there. Ruth raised the points about IT, which we've dealt with, and also issues about the reporting of COVID from patients presenting at ITU, which we've taken some actions on. John Rigglesford referred to some correspondence we've seen as Council of Governors about who gets vaccinated when, and the importance of following the government prioritisation and recognising issues of equity of access are being addressed best they can with the government guidelines, but we noted all of that. And last but by no means least, we had a request from John Boat that we give some consideration to whether or not we might be able to commemorate Captain Tom in some way at Chesterfield Royal in recognition of his £33 million contribution to NHS charities, and by perhaps naming a ward or an area after him. So we've taken an action to give that some further consideration. So that's the full list, and now colleagues who weren't there for the earlier discussion know those issues we've tackled and those issues that we'll need to return to out with the meeting. But at least the record now is complete. So thank you for that, and thank you to colleagues who have been flexible and agile in your response to some of those issues that came to the fore in that discussion. Which brings us on to item 8, and over to you, Margaret, in terms of governor feedback, please.
Right, I just wanted to highlight a couple of things, because I've now picked up some meetings that Denise used to go to in the wider system area. So there are just a couple of things. I'm now part of the League Governors Association, and they organised a national session with a gentleman from NHS providers to feedback. I think Vicky alluded to a consultation document that's been sent out, and the Governors Association were asked to feed into that about the further development of ICSs. That meeting was quite concerning from a governor perspective, I found. There were suggestions that the Department of Health and Social Care hadn't really given a lot of thought to governance within ICSs nationally, and there were other suggestions that NHS England didn't really feel that the Foundation Trust governance system had worked very well, and really it sort of left us feeling a little uneasy about how the future was going to pan out. The League Governors Association did agree on a form of feedback back to the centre to express some of those concerns, because even in ICSs, which are fairly well developed, there didn't seem to be a very robust governance procedure and system there. So that was concerning. However, also Vicky alluded to the meeting that governors locally within the Derbyshire system had with John McDonald, and that was much more positive in terms of how locally the system is looking to formulate its sort of governance strategies. And as I say, going through the governance measures of success, I pointed out at that meeting with John that we do have a specific item on our measures of success that we regularly get feedback on around our system working, and he was really impressed with that, and he has actually asked if I can share a copy of our measures of success with him, which I haven't done yet, but I wanted to check that that was okay, that we should do that. But it is a document that's in the public domain since these are public meetings, and he was really impressed. But going through them today, it sort of highlights that quite a few of them have some reference to system working and links with the wider system. So it does actually illustrate that we are actually, as a governing body, aware of that, and so that's a lot, quite a lot more reassuring. I think the plan from that meeting was that the ICS, Joint of Care Derbyshire, are going to produce some sort of discussion paper and then get together a small group to sort of work on how governance in the system will work. So I just wanted to let the rest of the governors know that we have got some links in there, and it is being looked at. So that was it really, thank you.
You're on mute, Helen.
Thank you. Well done, Margaret. I was just saying, given the concerns about, factoring governors into future governance arrangements, I think it's been really helpful to have Vicky here today, because I got a real sense from Vicky that in the Derbyshire context, they're keen to involve governors in shaping all of that. So we'll work with Vicky and colleagues to make sure that's followed through on. Anybody want to raise anything on the back of Margaret's report? No, thank you very much. In which case, let's go to the quality accounts, please, Krishna.
Thank you, Helen. This is really just to sort of give the heads up, really, of sort of what we're planning to do and just the timeline for the quality account that obviously takes place for the activities within 2020 and going into the end of March this year. So from a Council of Governors, it's really sort of just highlighting, obviously, that the commentary sort of from yourselves from a Council of Governors point of view will be requested, and the time frame from that is just included in the update. So that will be sort of draft quality account from the 7th of April, and then to provide the commentary between the 7th of April to the 7th of May, and then we will be able to go for sign-off from the board. It's just really just to give a sort of an update, really.
So it's a slightly modified approach this year for reasons you understand, but we'll still have the input from the Council of Governors through the committee. Are governors content with that approach? I'll take that as an assent. Thank you very much. So that brings us on now to a number of items by consent. So we can just note those. I haven't had any indication of anybody wanting to raise anything on those. So that then brings us to AOB. Are there any items of AOB that anybody would like to raise? No. Next meeting is on the 15th of April, but of course we will continue with our informal monthly updates between now and then. I think everybody's finding them a valuable way of kind of staying in touch and keeping on top of things in a fast moving environment. But next formal meeting is the 15th. And we will now review the meeting. For new governors, we pause with the words of the great prayer to reflect on what we've done and what we failed to do during the meeting. But usually with reference to leading the Chesterfield way, how are we role modelling the behaviours that we encourage and support others in showing, or just, in some more informal reflections. And I'd like to start, if I may please, with our new governors. It's that time of year when we've new governors, and we've been very pleased to welcome our new governors onto the council. And of course, you've met your other colleagues in informal settings, but this will be our first formal council meeting. And as such, it will be really good to have some thoughts from you. Is it what you expected, or any other thoughts? Who'd like to kick off? Eddie, let me ask you. You're rarely backwards and coming forwards. What did you make of it all?
Unfortunately, I missed the first part because I've been interviewing today, hence I'm kind of looking smart in my shirt and tie. But the bits I saw were very interesting, and I think it is what I expected. But I think it's the amount of honesty and communication is kind of very interesting and refreshing. So yes, it's very good. Thank you. Good. You'll be back for more. Thank you, Eddie. Graham, how was it for you?
I found it very interesting. I had a little problem with Teams on the informal bit of the governors' meeting. It switched me out, so I had to then log in again. But apart from that, I mean, information-wise, being a newbie and it all being new to me, I found it really interesting, really good. I tend to be writing up notes of everything that happens anyway and write it again when we finish this, and I've done that with each meeting to, if you like, help me absorb the information, because a bit of it is information overload when you're a newbie, especially when you're not in the medical NHS side, but thoroughly enjoying it and just trying to get up to speed as quickly as possible so I can be effective for you all.
Well, right. Thank you, Graham. Pervez, how have you found the meeting?
I think very reassuring would be the word, though information overload is still a question, a genuine question, but I'm sure in due course members will have areas of their concern and areas of be able to contribute, digest.
Thank you very much, Pervez. Graham, you should take some comfort from the fact that a hospital consultant at Chesterfield for decades is also noticing the extent of the information shared. So it might be all down to the fact you're new.
Oh, good. Well, that's good to hear. We always used to say in the electricity business, a little knowledge is dangerous, because all the people that thought they could do these little jobs at home usually ended up injuring themselves, and we ended up picking the pieces up or doing the inquests. But yeah, very good. Thank you.
Tom, how did you find the meeting?
Excellent, very reassuring that an organisation is doing its utmost to deal with these exceptional times, you know, both with regards to the direct COVID stuff and patients with all other medical conditions. I found there was a heck of a lot to read beforehand, but I managed to get through most of it. It's a very long, it's a very steep learning curve. You may find that I'm a little bit more talkative in the future when I've learned the ropes and the stabilisers are off.
Very good, very good. Any comments from more long-standing members of the Council of Governors about today's meeting? Lynn? Lynn, you're on mute.
Sorry, I was just saying I think it's actually gone really well. I think that you know, we certainly seem to get the most out of these virtual meetings. I think that the NED reports were brilliant. You know, they were to the point, and I thought they were excellent. And I'd just like to say a big thank you to Nicola for the induction programme that she put together, not only for new governors but for long-standing governors. I found it really, really good. And yeah, I think she's done a really good job. So thank you for that.
Thanks, Lynn. And Nicola had to move on to a completely new way of doing it. So yeah, well done. Derek.
Yes, just to say I've come through the meeting and I find myself assured that the hospital is doing all that can be expected and perhaps a little bit more in these strange and trying times. So you know, I feel if I'm asked in the street by a constituent, how's the hospital getting on, I will just say that. Very good. Well done, everybody.
Thanks, Derek. Norman?
Hi, Helen. Can you hear me now?
Yes, loud and clear.
Oh, right. Just to say, following on from what I think I said at the last meeting, that bearing in mind the times and doing everything virtually, the quality of the meeting has been very good. The content, it proves that the hospital's still ticking along, still working very well, and that we're getting, as governors, all the information from the non-execs and the execs. And I feel, as a public governor, I feel very reassured. And just one thing, if I could raise, that with reference to the Facebook site, to John Thorpe and Sarah Turner Saint, I don't know if that lady goes to bed or not, because no matter what hour of day, she seems to assist members of staff with every question or comment that's made. She comes in and helps. So I'd like to give a good pat on the back to those two people for getting information out and getting it out quickly. So if you could do that, Ellen, I'd be very pleased.
We will indeed, and it's a well-due thanks and appreciation. So thank you, Norman.
Thank you.
We've got some other hands up. Mike.
I'd like to echo Norman's sentiments, but also the forecast for the weekend is for cold and more snow. So could I place an order with Lynn for a woolly hat, please?
Well, only after she's knitted my stroke consultant, but we'll put you in the queue.
But I'd like a snood as well.
I won't ask you what size your head is, Mike.
I won't tell you.
Very good. Luke.
Hello. Yeah, it was just a quick question because I think we're all kind of feeling quite assured by coming to these meetings. But I was aware at the beginning some governors weren't feeling like they were able to engage with these virtual meetings particularly well. So I was just wondering whether we're doing anything to make sure they're assured as well, or is it kind of? I don't know if Nicola's given any updates or not. I'm not sure.
Hey, Nicola's doing as much as is humanly possible. As you might expect, so they're getting all the briefing. Because some of them who aren't able to beforehand also don't like a lot of updates by email. So where that's the case, Nicola's printing everything out and really trying to keep colleagues in the loop. And really encouragingly, we've had some nice comments in terms of them recognising that effort. I don't know if there's anything you want to add, Nicola.
No, just other than we're trying our best to sort of make them feel welcome and joined in. So it is really difficult when we're in this situation, but we are trying to make them feel as included as possible.
That sounds great. It was just to check in on them as well.
Yeah, thank you.
Oh, good call. Thank you very much, Luke. Well, I think we should draw proceedings to a close. A huge thank you to Angie and the whole of the exec team for the splendid job you're doing. I know it's been said a lot this afternoon, but I hope you're going out with the spring in your step to face whatever it is you might be facing for the rest of the afternoon, because we're very grateful and appreciative of all that you're doing so very well. And to my governor colleagues, stay safe.
Thanks. Bye.
Thank you.
Thank you.
Thank you, Helen. You too.
Thanks, everyone.
Thanks. Bye.